In fact, what is very important to understand is that VBHC has been at the heart of EMC since day one. From the moment we established the center, we intentionally built our model around the concept of an IPU, an integrated practice unit, focused specifically on spine surgery and orthopedic surgery and musculoskeletal issues. So that's why we wanted our IPU to be structured to provide comprehensive care around the precise pathology. That means we have put in our center all what would serve the pathology we want to be specialized in. So, of course, in this case, orthopedic and spine surgery. So we have created an adequate and a comprehensive and full-fledged radiology department, because it's related, of course, to complete the cycle of care in the spine and musculoskeletal issues, physiotherapy, neurology department, rheumatology, pain medicine, nutrition, some psychology also, and all these departments are organized around the patient's need, not the specialty only, the patient's need. This setup allowed us to ensure, one, accurate diagnosis, and the multidisciplinary collaboration between all the departments, and a seamless care across the entire journey of care, especially for surgical candidates. We have also created a dedicated VBHC implementation team. What is paramedical, the IT, and all the people who works and help us in ensuring a good data outcome collection. We have also partnered since day one with CAPADEV, which is a specialized, who are specialized in VBHC implementation, and we are working under their umbrella with ICHOM, with the umbrella of ICHOM to supervise if the work is done as per the rules and regulation and the principle and the guidelines of ICHOM. I personally completed, of course, the VBHC certification program offered by ICHOM, which was taught by Scott Vallas. I have been to Harvard, of course, with Michael Porter, where I have done and studied exactly what is VBHC, the principle of VBHC, how we implement and manage the healthcare delivery, how we have to measure the outcomes, what is the strategy in value-based healthcare. And since I am a spine surgeon, we have wanted, and an orthopedic surgeon, of course, we wanted to implement the ICHOM standard set for low back pain. After carefully having localized the assessment tools to suit our populations, we did not only do a translation of the data, not at all. We did a localization by a third party which is certified third party to localize all the question of the data set, okay? And then we have, this was also facilitated by CAPADEV to ensure a contextual relevance while adhering to the ICHOM's global standards. Crucially, we're one of the only institutions in the region practicing a full transparency in reporting and monitoring and sharing outcomes data in line with the ICHOM guidelines. This is what we wanted since the beginning. It's not a matter of marketing. It's a matter of applying rules, which is not always easy, following all the regulation and the guidelines of ICHOM in order to be able to give good outcomes and valuable outcomes. Finally, we have collaborated with insurance companies, major insurer companies here, to pilot bundled payment model by applying the value-based healthcare model to all low back pain, to all our patients who have low back pain. We did not at all just selected some patients, because we didn't want to fall into the cherry picking problem, not at all. We wanted all our patients who have to be operated or treated from their low back pain to be treated as per the value-based healthcare principles. And here really, we need to be very clear that having partnered with the insurance companies to ensure a bundled payment agreement was very important. And really we want to thank these companies like Taamiya, like Bupa, like Takaful Rashhi, who were very interested in the VBHC and in offering to their patient a really excellent cycle of care. So throughout patient education and shared decision making, we wanted the patient centricity to be the central pillar. Our patients were always informed, involved, and empowered every step of the way to help us taking the right decision. So the patient was the center of our decision. We did not take the decision as a clinician only. We took the decisions as a clinician based on what the patient used to need and what the patient wanted. So because EMC, European Medical Center, operates as an IPU, we've built highly specialized care pathway around spine surgery and orthopedic surgery. This translates into greater precision, consistency, and accountability at every step. We have trained our surgeons and supported our teams to operate as a cohesive unit. This is very important. Each member of the team has its importance, and each role within the pathway that has been optimized to reduce waste, minimize delays, and enhance, of course, safety. Our measurement approach is robust. We collect both PROMs and CRONs. Most importantly, we use this data only for compliance, but we don't use this data for compliance only, but to drive real improvement. We built a centralized outcome registry, and currently we are working on integrating it with our EHR systems to track every patient's journey longitudinally. Monthly, we conduct multidisciplinary outcome review board to examine trends and identify variants and implement corrective actions. Our patient centricity, in fact, goes beyond surveys. We engage patients in co-designing care plans, we explain the risks, we expect benefits, and where possible, we enroll their families to support informed choices and reduce pre-surgical anxieties and post-surgical anxieties, of course. I think that the dual lens, seeing outcomes through clinical metrics and through the patient lived experience, is how we constantly improve our care. I would like to insist on that the patient needs to be always in the decision that we are taking for his care. This is, after all, our main reason to treat him. He has the choice to decide about which treatment to adopt in order to, and what he thinks may be the most benefit, brings the most benefit to him. Culture is everything, you know. When you're implementing VBHC especially, we've built a system where data collection is just the beginning, not everything. What matters is how the team reflects on it, learns from it, and adapts behavior accordingly. At EMC, we are regularly reviewing our outcome data and patient satisfaction scores. This is very important. Not in isolation, but in open dialogue with our clinical team. We also dialogue with the patient who were operated. We are trying to manage their experience. We try to, above and beyond going to PROMs, we talk to them on a daily basis life. How is it impacting their daily life? And this is very, very, very important. So we, as I told you, we regularly review outcome data and patient satisfaction scores. We open dialogue with the clinical teams. And what's particularly important in Saudi Arabia is that cultural expectations of care differ from the Western settings. In our region, it's not exactly the same. That's why we do not blindly adopt international models. We try to adapt them to fit the population. We conduct monthly KPIs reviews. We listen to feedback from nurses, administrators, physicians, and most importantly, patients. We actively track care gaps and potential pitfalls. This is very important. And we foster a safe environment for teams to question practices and propose improvements. To boost morale and engagement, we're introducing a VBHC champion for the month. This is a kind of recognition program. We also hold regular training workshops for focused to be focused on empathy, communication. This is very difficult because, often the patient want more than what we think they need. So communicating with them is very important. And we need to explain always to the team what is the most important part in the patient experience. Because these are areas that are often under-addressed in traditional clinical education. And one of the hardest yet most important shifts has been helping physicians to see the illness through the patient's eyes. We are all doctors, and the doctor's aim is always to heal. Okay, you are healed, this is very good, we don't care about the rest. No, we want to understand if what we offer to the patient, the outcome offered to the patient, was what the patient was expecting. If this was not what he was expecting, so it's because often it's not only from the lens of science, it's lens LENS, but it's through lived emotions and personal goals. That's where true patient centricity and patient-centered care begins. This is how we use it. Do I believe other countries could learn from in their own VBAC journey? Well, we have the immense chance that Saudi Arabia has embraced the bold transformation agenda under the Vision 2030 of His Royal Highness Prince Mohammed bin Salman. And healthcare is a core pillar. And one of the most striking shifts is the national level commitment to VBHC. And you know that the headquarters of the VBHC is here in Saudi Arabia, and the CEO is Dr. Reem Al Bnayan, and it's really this country is engaging totally in the transformation of healthcare, and this is very important. There is a clear top-down message. Healthcare must move from volume to value, from doctor-centric to patient-centric care. That alignment from regulatory bodies to private sector hospital is a game changer. Really, it's a game changer because it takes a high-level decision to be able to implement it on the private and on the public level. We are also seeing a rise in think tanks and academic institutions dedicated to VBHC awareness and ICHOM adoption. ICHOM people are coming here. They are hugely helping us, activating the implementation, helping us for the implementation, and this is wonderful. The public-private partnerships are driving rapid innovations, especially in digital health and integrated care models. Insurance reforms are paving the way for bundled payment and performance-based reimbursement, which are critical levers for VBHC, as you know it very well. And perhaps most inspiring is the emerging generation of young, tech-savvy healthcare professionals that are open to change, fluent in data, and eager to drive value. So this cultural shift is fertile ground for VBHC to not only grow, but to lead globally. And this is important to understand that it's not only about patient, not only about the doctor, it's about a team working to reach this goal of applying principle that at the end of the day are offering value to the patient. It's enough to become a patient to understand the importance of value-based healthcare, of seeing things from the patient's point of view and not from the doctor's point of view. When you want to draw blood, for instance, from a patient to do blood test, if you manage to do it from the first time, it's excellent. If your nurse struggles to do it, the patient will have a bad experience, even though at the end of the day, we will have blood and we will have the tests. But the experience of the patient in this case is extremely important, really. And that's what is unique to learn from the journey here in Saudi Arabia. So one of our first hurdles was aligning physicians and stakeholders. You are trying to explain to them that it has to be the concept, they have to apply the concept of the patient centricity, which frankly contradicts a little bit with the traditional model of medical training that prioritizes clinician and the clinical reported outcomes. The doctors always want to see the result. But how did we achieve the result? How was the journey? Usually this was not really in our education, in our medical school. Then we had to ensure data completeness and quality, especially for PROMs. It has required extensive efforts, a lot of extensive effort to translate and localize the data set of the ICHOM to have exactly things done as per the guidelines imposed to us by the ICHOM. We've worked also hard to avoid mediatization for mediatization, you know, because everyone talks about VBHC, but when you come to the implementation, rare are those who are really implementing this principle as we are doing them. Then it was rather hard to convince insurers to move toward bundled payment. It required months of dialogue and of demonstrating trust in our clinical outcomes and of interest to both the payers and the providers and for the patient. That was very important. And like any VBHC model, we had to actively resist the temptation of cherry-picking patients to improve our numbers. We committed to applying our model, all the equitability. And we know since we are with CappaDev, we are on their platform. So all the collection of the data is done by a third party, which means that we cannot play and bias our data. Our data is collected by the third party through the patient, which gives us a more transparent, and we can more transparently talk about our result. Our opportunities now is that we have positioned EMC as a regional leader in outcome-based care, particularly in spine and musculoskeletal health. This is for sure. We have attracted international attention and partnership through ICHOM alignment and transparency, and for that ICHOM helped us a lot to have a bigger and more exposure to what we are doing, knowing that what we are doing is being done in a transparent manner without any bias. Other opportunities, enhancing our internal approach, operations through data-driven decision. This is very important to improve both patient outcome and cost efficiency. And most importantly, we have rebuild patient trust and satisfaction. This is very important by offering them a care that is transparent, evidence-based, and human-centered, and specially centered as they were expecting. Not more, not less. And to be able to do that, of course, it took us to discuss with them, to talk to them, to understand what they need, to understand what are their expectations, and to try to align with them to ensure the best outcome, a good outcome, an excellent outcome. Because also we must not forget that the health is very important and that we need to guide them for the best outcome, but also they need to align with us to have this best outcome. I may say we couldn't have done it without ICHOM. I mean, very honestly, a very cooperative team, always answering our question. They were more than a benchmark. They have been a catalyst, always helping us to improve our data collection manner. We have adopted our low back pain standard set and work with them. They advised us to have also the partnership with CappaDev to find and localize tools for regional applicability while maintaining a global rigor. I mean, it wouldn't have been possible without them. So the methodology, ICHOM methodology, helped us shift from measuring outputs to measuring what truly matters to the patient, the PROMs. It helped us a lot, education, talking to the members, to the team of ICHOM. It was crucial for us and always pushing, helping us to continue, even when sometimes it was very hard to continue. So their framework also guided our data collection workflows and enabled the cultural shift internally. That is very important. Rather than seeing outcomes measurement as a regularly checkbox, our clinician began to see it as a pathway to excellence. It's not just because we want to be ICHOM accredited or ICHOM certified. No, it became in our DNA, and our physician and all who are working with us believed that this will be a pathway to excellence to ensure the best outcomes. And most importantly, ICHOM connected with us with a global network of like-minded institutions, allowing us to compare, learn, and continuously evolve. This is very important for us. This was very, very important for us.